Hey, good afternoon, everybody, and thanks for joining. This is a great talk. This is a third talk in a series of three on women's heart disease, and I think you're going to enjoy it. We have a great guest today, Dr. Zarina Sharalaya is going to be joining us very shortly. But first, I want to thank our host, Cardiovisual, for hosting this program. And, via their free educational videos, they provide clinicians with educational material to better educate their patients with heart health, with heart disease, and diabetes. Thank you for joining and welcome.
Thank you for having me.
Yeah, so Zarina, I actually came across your post, and one of them said, it talked about the challenges that you faced when you're going through this process, and it had to do with you being a female and some of the hurdles that you faced. So you decided not to become just a cardiologist, but an interventional cardiologist, right?
Yes, yes.
Tell us a bit about that, and then tell our audience a bit about your background.
Yeah. So basically, I'm fairly early in my career. I have been in private practice for about 2.5 years since I finished fellowship. And I was drawn to cardiology kind of in the first place back in, I think it was my third year of medical school. And I had just rotated through the acute coronary service. And before that, I was full on track to be ophthalmology, fully on board with that. But after this ACS rotation, I was convinced that cardiac physiology and taking care of really sick shock patients is really what I was meant to do. And so I decided on cardiology halfway through med school, and then interventional cardiology specifically more in the middle of my fellowship, because I just love doing procedures and the ability to save somebody's life pretty instantly when they come in with a heart attack. That feeling is just unparalleled in my opinion. So in terms of, there is a big gender disparity when it comes to women in cardiology, specifically interventional cardiology. There's only 4% of practicing interventional cardiologists are women. And I think that, there's just so much noise out there just preventing a lot of women from wanting to go into this subspecialty primarily because of work-life balance concerns and things like that, and raising a family and all of that. So that's kind of why my whole professional Instagram page is not only geared towards medical content, but also to sort of serve as inspiration for women out there who are thinking about cardiology or becoming an interventionalist, and just so that people know that it is doable.
Your content is excellent.
Thank you.
And I would urge everybody to go check her out.
Thank you.
Yeah, it's great stuff. I look at it all the time. So thanks for doing that. We really need education like this.
Absolutely.
So let's get into it. We're going to talk about menopausal changes first. Then we're going to talk about microvascular diseases in women, because heart disease presents differently. And then we're going to get into the broken heart syndrome, the Takotsubo cardiomyopathy, and then maybe talk a bit about heart failure and how that is different in women. So speaking of menopausal changes, I get asked this question all the time. I'm an ER doctor, and they say, hey, so I'm going through menopause right now. I might increase risk. And with regards to all the other biometrics, blood pressure, heart rate, all those things, how is the premenopausal or perimenopausal women different from those patients who have actually gone through menopause? What happens to the heart?
Yeah, so basically it all has to do with the hormonal changes that take place around menopause. So average age of menopause is around 52, and really involves a drop in estrogen and progesterone. It leads to a lot of common symptoms of menopause, things that include headaches, hot flashes, insomnia. But of course, with all of that comes with it the very important changes in cardiovascular health for women, specifically raising their risk of cardiovascular disease. So after menopause, the incidence and severity of coronary disease increases abruptly, with about a 3 times increased rate of cardiovascular disease after menopause sets in. And really, obesity rates kind of go up around this time because it becomes a lot harder to lose weight, that perimenopause time frame. In terms of lipids, after menopause sets in, your estrogen levels go down. So with that comes a rise in your LDL, bad cholesterol, triglycerides go up, and then your HDL decreases. So for a long time, there is a cardioprotective effect of estrogen, but for a long time it was believed that supplementing estrogen or exogenous estrogen actually reduces your risk. But as far as we know now from a lot of data and things, that supplementing estrogen does not actually reduce your risk of cardiovascular disease. And if your goal is to reduce LDL, um, estrogen is not the way to do it, basically. So,
Mhm.
with that being said, if women need hormone replacement therapy for other reasons, whether it's symptom control for menopausal symptoms, that is definitely okay as long as it's given to the right
Mhm.
patient. So if they're early on in their menopause and they have no history of cardiovascular disease, those patients absolutely are safe to be on hormone replacement therapy. But if they've had strokes in the past or a heart attack in the past, definitely would avoid hormone replacement therapy. So at the end of the day, I just recommend that perimenopausal women just stay on top of their risk factors, have your cholesterol checked regularly, and statins would really be the first line way to bring down cholesterol if it is indicated based on your risk. So,
Yeah, I still see patients coming in all the time. Well, I shouldn't say that, not all the time, but I still see patients who come in on estrogen therapy and like, is this a good thing? Should I stop this? And, from an ER standpoint, there's no way to really answer that correctly, right? Because you really have to go through the entire workup and discuss the
exactly.
benefits.
Yeah,
So,
it's really combing through their history to kind of tease that out. Yeah.
yeah, and, like you said, there is some protection, I guess, earlier on, but
Yes.
yeah, it's one of these things, right? So we really, I'm blown away by the facts that heart disease is still the number one killer in women,
Mhm.
and the data, I think, correct me if I'm wrong, but I think the data still says that post heart attack, 1 year after a heart attack, women still have a worse prognosis. Am I right about that?
Yes, 100%. And there's a lot of data being done out there. And just now, as more and more women are being incorporated into research, there's been such a lack of research on heart disease in women because there just weren't included in the trials. And so we're really trying to get at this gender disparity that exists in outcomes
Mm.
when it comes to women who present with heart disease. So, I mean, they get stents less frequently. They get tested for cardiovascular disease less frequently than men. And it's, I think, a multifactorial issue, which you could spend over an hour talking about, but it is a big problem.
Yeah, I don't like the term atypical presentation in women. It's one of the, I might be right or wrong, I'm not sure, but you also mentioned in one of your posts about the fault in recognizing disease in women. So it's not about, it's not about the patient, it's about the clinicians not recognizing what those symptoms are and acting appropriately. Has
Correct.
that changed over time?
I mean, I think now that there's more light being shed on it by different organizations like
Mm.
Cardiovisual, American Heart Association has really done a lot with their Go Red for Women campaign and just kind of sharing what the typical symptoms are in women. And it's not that they're atypical, they're just typical for women. Things like shortness of breath, fatigue, epigastric, like GI symptoms that are the more common ways that women present with coronary syndromes.
And maybe that's something to do with the way the pathophysiology works. So can we get into that, the pathophysiology, as to why they may present in this quote different way?
Yeah, I think women are affected by they present in different ways with heart disease, but then they're also affected by different heart conditions, specifically
Mm.
more commonly than men. And microvascular disease is one of those conditions that is, we're just now learning more and more about because there's a lot of data being done with it. But oftentimes, as medical providers and even a lot of cardiologists, we're just focused primarily on disease of the epicardial blood vessels, meaning the large coronaries that sit on top of the heart that supply your heart muscle. So these are the ones that we often implicate in a heart attack when somebody comes in. But what now is coming more to light is a growing body of research showing that there is a condition called microvascular disease that truly affects the very tiny arteries and arterioles that supply your heart muscle. And this
Mm.
condition basically, it doesn't allow for normal dilation of your smaller arteries, which can then result in symptoms very similar to mainstream coronary disease. So these patients come in shortness of breath with exertion, chest pain with exertion, and basically it's very limiting to a patient's quality of life and their functional capacity, how much they're able to do. So we know that women are at much higher risk of this condition than men. So the risk factors for microvascular disease are high blood pressure, obesity, diabetes, and female gender. So this condition specifically is something that often goes missed because people just aren't looking for it. And we diagnose it using a very specific kind of stress test. So a PET stress test, which is, a lot of institutions don't even have that capability. Or you can diagnose it with a heart catheterization, sort of looking at the blood flow reserve in your coronaries, which is reduced in patients with this condition. So overall, to treat microvascular disease, you usually use either a calcium channel blocker or a nitrate. So sort of run-of-the-mill blood pressure medicines to dilate your arteries, and people feel better with that. Yeah, there's the microvascular disease is one of those things that many cardiologists even miss it because they're just not looking for it in women, especially.
Yeah, I think it is confusing sometimes when patients come in and they don't have the classic symptoms, right? The classic depression, the male symptoms, I should say, right? And I'm guessing that a loss of estrogen over time has something to do with the way the microvascular structures work, right?
Probably.
Is that correct?
And then we know that high blood pressure also is very much implicated. So around perimenopausal time is definitely when this condition can present.
Mm,
But of course, we know that diabetes, high blood pressure, as they similarly remodel the epicardial disease coronaries and predispose you to plaque buildup in the large coronaries, it can also affect your microvasculature the same way.
right. That's I think the more studies come out, the better we'll
Yes.
understand the different presentations, and just change this entire the swing. The pendulum's got to swing back the way we want it to, right? So it's
Right.
hopefully research will do that for
Yep.
us. Let me ask you about a case. This happens to us sometimes, not very commonly, but the classic case that I had was a patient who came down from the ICU over the death of her child, and she was extremely upset, and she was visibly upset, and she then complained of having chest pain. And of course, the first knee-jerk response was she's anxious. She's having an anxiety reaction, and she's a younger woman. She's in the 45 to 50 age range, and the knee-jerk response was just anxiety. But my resident went ahead, being a great resident, went ahead and got an ECG, and it showed ST elevations. She went to the cath lab, and she was diagnosed as having this thing we call broken heart syndrome, Takotsubo cardiomyopathy. Can we get in that a little bit and talk to our audience about the prevalence and how common it is nowadays?
Yeah, so Takotsubo or stress cardiomyopathy, broken heart syndrome, as it's
Mm-hmm.
known in layman's terms, is overall still pretty rare, about 2% incidence, but it can really very closely mimic a heart attack. And what happens is basically you get, at least on imaging, it's kind of characterized by a classic appearance on the echocardiogram, where you get this kind of transient regional LV systolic dysfunction. And basically, on the echo, you'll see that the apex of the heart is sort of ballooned out. And so they'll come in, usually, it affects women more predominantly, and it's triggered by a surge of catecholamines. And that can be kind of triggered by really emotional, intense distress or even physical distress, and they'll come in presenting like a heart attack. Usually the workup involves an EKG, an echo, which will usually show that kind of characteristic finding of the apical ballooning of the left ventricle. And we take them to the cath lab just to kind of further understand what's going on. And by and large, they will have minimal to no coronary disease. And so, in terms of how we treat this condition, I mean, a lot of times the LV function will go down. And usually the condition is usually reversible within about a few weeks to a month or so with heart failure medications. But truly, when they're in the hospital, the mortality rates of these patients is pretty similar to what it is for a patient that comes in even with a regular heart attack. So, um, at least in the hospital while they're there. So, these patients can have recurrence of this condition. It's rare, about 1 to 2% per year, but this thing can come back if it's happened to you once. And I think it's always amazing when these patients come in because it's such a testament to the effect of how stress can really affect your heart, and that stress really can cause a heart attack. So I think that, and especially in women, this seems to be the case.
Yeah, I don't think we appreciate how serious it really is, and the classic, the pitfall is to say, hey, that's not your heart, that's anxiety. That happens. That still happens right now.
Yep.
Matter of fact, I had a patient who had who came in, I think, her fourth visit. I talked
Mhm.
about this in the our last live, and she said she kept passing out, and she had ARVD. And I said, well, you've been to the ER doctor, cardiologist, so why do you think this is something different? And her response to me was, well, doctor, is it normal for people to pass out while they're lying in bed? And suddenly I was like, okay, that's not right. And
Wow.
we looked further, and she had ARVD. So
Hmm.
uh,
It's amazing.
we got to do a better job as clinicians, I think, to really understand,
Yeah.
history and all that.
Yep.
Um, yeah, great. So we do have some questions, but let's pivot a bit into heart failure in
Mhm.
women. Heart failure in women. How does heart failure in women differ from heart failure in men? Can you go through that a little bit with us?
Yeah, so generally there's two different kinds of broad categories of heart failure, and we call one heart failure with preserved ejection fraction versus heart failure with reduced ejection fraction. So HFrEF and HFpEF. And so HFpEF is basically, again, much more common in women, and it really represents the fact that your left ventricle is very stiff and there's a problem with the relaxation part of the cardiac cycle. So basically, the main risk factor for HFpEF is a history of hypertension, obesity, diabetes, again, much more common in women, but it can cause all of the same presenting symptoms of HFrEF or if you have a weaker pump function. So you basically diagnose it with an echocardiogram and you really do your best to try to, keep the fluid off, which is what kind of makes these patients keep coming back, and then manage their risk factors such as obesity, counsel them on weight loss, manage their blood pressure, etc. But heart failure in women, again, HFpEF is a little bit more common, but they can also experience a condition called peripartum cardiomyopathy, which is usually when the pumping function goes down around the time of pregnancy or in the postpartum state. So this is another kind of condition that we really have to be watchful for pregnant patients or those who are just postpartum, because a lot of the symptoms of pregnancy are sort of mild forms of heart failure symptoms. You get short of breath at times, you get leg swelling and things but you just have to be much more mindful especially if somebody has a family history of heart disease or if they're showing symptoms out of proportion to normal pregnancy.
Yeah, true. Very true, and kind of tough to can really parse those two things out. So
Yeah,
thank you so much. I'm looking here at the board here, and there are some questions here. So want to leave enough time for these questions. Want to do a couple of them?
sure. Let's do it.
All right. So first question here is, what are the most ignored signs in women that could indicate a heart disease?
So I think that the most common thing that I find is that women come in with this epigastric burning sensation. Um, and so I would say that for sure. And then shortness of breath. These are two symptoms that um, a lot of women come in with. And the go-to thing is to either put them on antacids or say, oh, you're short of breath or you're having palpitations. You probably have anxiety. You're so young. Let's either just put you on a PPI or start some anxiety medicine and see how you do, kind of thing. But these are very common symptoms in women
Mm-hmm.
that should, if they don't, especially if they don't immediately get better on, an antacid or a Tums or something, you should be looking further.
Yeah, it's again one of those pitfalls, right? It's not always good.
Yes.
So
Yeah.
let's be careful about that. Here's a question for you: how can back to the postmenopausal patient? How can you prevent heart problems in menopause? I'm assuming they're saying if estrogen is off the table,
Hmm.
how can these women then reduce their risk of heart disease after
Yeah.
menopause?
It's a really good question. And I think you really need to go see a cardiologist who understands prevention and specifically women's physiology, because um, at that point, if you don't have the usual risk factors like high blood pressure, diabetes, like you really want to do a deep dive of family history. You want to really understand your lipid profile, and that doesn't just include a basic lipid panel. It also includes looking further at things like lipoprotein A, looking at your inflammation profile, um, things that are not going to be checked by a regular family doctor necessarily. So I would say to prevent heart disease, definitely managing your risk factors early on. And a lot of that comes down to looking closely at your lipid profile, because that's the thing that usually goes out of whack after menopause hits, to determine, do we need to be more aggressive? Do we need to really focus in on lifestyle only, or do we need to think about things like medication to really lower your risk as much as possible?
Yeah, great, thank you. Let's dive into lipoprotein A. Again, one of these things where, most people don't know much about it, or the treatment, or how you actually, evaluate the patients. What are your thoughts on that?
Yeah, so it's again one of those things that we're learning more and more about. We don't have a great way to treat it right now, but we do know that lipoprotein A is a very more of a genetically based marker for heart disease. So, um, a lot of times, and it's unfortunately becoming more common, where I see 30-year-olds, 40-year-olds coming into the hospital with heart attacks, and we're like, what the heck's going on? Their LDL's like less than 100, and so you actually end up checking for lipoprotein A, and sure enough, it's positive. And so I think we have a target to say that, hey, this is probably the reason for why you have such premature coronary disease. And if you comb through their family history, more than likely you'll find a pattern of that in their family members. But it's an LDL like particle, basically lipoprotein A, that conveys a higher risk of cardiovascular disease. So unfortunately, we know that statins don't really reduce it. The only drug out there on the market that does reduce lipoprotein A at this time is the PCSK9 inhibitor like Repatha. But of course, those are not widely available. They're quite expensive and hard to qualify for. So there are a lot of different studies in the works to target lipoprotein A, but we don't have a specific great drug right now.
And that drug actually drives down the LDL, the regular LDL, quite a bit, right?
Yeah.
We got a picture of that with an LDL of like 10 or 20. I'm like, I was all freaked out by it, but
Yeah.
yeah.
We do know that there's no level of LDL that is too low. So.
Yeah. All right. So next question is, in Takotsubo, is there any relationship to left ventricular rupture? I guess they're saying, we'll take it, but what do you think of that? Do you see a correlation between those two things?
Generally not, just because it is more of a global process. When I think of LV rupture, I think more of like a ischemic etiology, where you have a specific coronary that has gone down. And so that part of the LV has basically formed a scar, and over time can become aneurysmal and things like that. So that is a very much more focused area, whereas I would say Takotsubo is more of a global kind of process that happens. So I personally haven't seen it, but
Yeah, from an ER standpoint, we'll see LV rupture in patients who've had a big MI that come in afterwards, and it's
yes.
catastrophic, right?
Yeah.
How about women with microvascular disease? Does that tend to put them at a higher risk for wall rupture? Because
No, I actually haven't seen that. No.
I haven't either. All right. So next question is, in our country, I'm not sure which country we're talking about, but I'd love to hear about it. In our country, MIs have become younger. I think they're saying that they're seeing them at a younger age.
Mm-hmm.
How is it in the other countries? And are there epidemiological reasons for that?
Yeah. I mean, unfortunately, it is very much the case here in the US. And, even when I was in training, I feel like it was very rare to see a 30-year-old come in with a heart attack. But now I can probably name or think of 4 or 5 patients that I've treated in the last year who've come in and they have LAD disease, which is kind of unheard of almost. But it used to be that patients, 30-year-old comes into the ER and you almost kind of write it off because they're coming in with chest pain, their workup's negative, and they go home. But they could truly have something going on. And I think that's unfortunately, because of diet reasons. I think that there's a lot of increased consumption of processed foods and things that just in the last 5 to 10 years, like we've just been sort of filling our bodies with. And I think that it really has done a number on our risk for cardiovascular disease from a very early age. And the risk factors themselves are setting in much earlier. A lot more people I see very early on having diabetes and high blood pressure that we're treating. And so I think that, it is very unfortunate, but I think diet has a lot to do with it, which can lead to all of the downstream risk
They
factors.
say something like 85% or even 90%, right, is diet induced. That's what some of the nutritionists say, at least. So
Yeah.
all right. So next question is, it's a long question. If a person has normal coronary arteries 2 years prior and now presents with ST changes and T-wave changes on the ECG, but the troponin is normal, is it repeating a cath?
I would say a heart cath is probably a little bit extreme, but I would probably do a deeper dive from a metabolic standpoint, looking at labs and things like that, understanding the history itself. If there are new abnormal EKG changes, I would either probably start with a non-invasive test, maybe
Mm,
either a nuclear stress test, or nowadays I've been really shifting my practice to coronary CTs, which are very helpful for looking at soft plaque and obstructive coronary disease. So.
right. Great. Fantastic. Well, I think we can probably just stop the questions here.
Yeah.
I do want to kind of focus back on you, your role as an ambassador for women in training, and just tell me something about how you've impacted the entire profession of cardiology and medicine for that reason.
Well, I think I'm pretty new to the whole professional Instagram space, but even in just a year's time, a little over that, it's just amazing to me how many women, not just in the US, but across the world, have reached out to me just kind of to get advice. How do you tune out all the noise saying that you can't do this and, you can't be pregnant in the cath lab and have a family and have a safe pregnancy, all of these things. So, it's just been really rewarding to talk to women like this and kind of share different reels about, and the full disclosure, I am pregnant right now. And so I've been posting a lot of videos in terms of how I've been doing it in the cath lab and, safely having um, protection when it comes to radiation and all of that stuff. So uh, I think that it's only through examples and so people can actually see that there are others out there who have done it, and how they've done it, that we can really just change the narrative when it comes to so few women going into cardiology and interventional
Yeah,
cardiology.
I think you pinned a post. I think of you've got your scrubs on and your gown
Mhm.
on. You're clipping on the radiation badge, and you're pregnant.
Yep. Yep.
37 weeks pregnant. You're 37 years old, right? And they're
Yes.
something like that. You said something. How
Yeah.
far along?
23 weeks.
Well,
About-
congratulations. That's
Thank
fantastic.
you. Thank you. Thank you. Yes.
Fantastic.
Thank you.
Yeah, I think there's a lot more work to be done.
Yeah.
And folks, you should definitely check her page out. It's called From the Heart, right?
Yes. From the heart.
At From
Yes.
the Heart. Go ahead and check out Zarina's page. I think it's very, very useful, very great information. So thanks for what you do. Whoops, there's one more patient question here. Time for one more, you think?
Sure.
All right, so this is definitely a question for you and not for me. How will genomic data change the way we manage and treat cardiovascular diseases in the future? That's a
It's a
big question.
great question. I think that there's so much being done in this space, and I am not super connected with that part of the data, but for many years, patients who have had heart failure, especially they have a family history track record of heart failure, and they themselves then present with heart failure. There's a lot of genetic testing that is already being done to sort of show that there is a gene connecting all of those heart failure cases. So from that standpoint, it's just helpful and able in terms of guiding them and counseling them in the future if they're family planning and things like that. But when it comes to cardiovascular risk, and particularly these cases with lipoprotein A that's kind of run through the family, I think that it will be very interesting to see that probably in the next 5 to 10 years, we're going to have a much better sort of genetically guided way to address coronary disease and prevention in the future. To say that, maybe there's a gene out there that we test for and say, hey, you might not need a statin because you don't have this gene that's positive. I think that it'll be much more personalized medicine in that way once
Mhm.
we get more data back.
Absolutely. I think it's in that direction, no question about it, right?
Yes.
So excellent. Hey, listen, thank you. We are out of time. So thank you so much for taking the time to join us today in our third episode, the last episode on women's cardiac health. I thought it was great information you put out there. Folks, go check out her webpage also, or just Instagram right now?
Just Instagram right now.
Instagram.
Yeah.
page, From the Heart. It's great stuff. So be on the lookout for more stuff coming from her. We'll get you back on and do more
Perfect.
chit chatting with you about this also.
Sounds
But
good.
for now, guys, thank you so much for joining me, and thanks to Cardiovisual for hosting this this tremendous series. I think really appreciate it. And until next week, for now, take care.